Great. So Michelle and Blair, come on up. All right. We're going to move on to talk about solutions at the federal level. And I guess the empty chair there is symbolic of the fact that we actually had a number of Hill staffers who signed up to be here. But given what's going on right now in this town, they couldn't. They have a reconciliation bill to review and talk about. So maybe we'll talk about that a little bit since it's the elephant in the room. But really, we have Blair Elliott, who's a health policy advisor for Third Way's economic program, but also previously had a role.
I previously served on the healthcare team at the Domestic Policy Council in the Biden admin. So now working at Third Way, but also previously wore the Biden admin hat.
Yep. And Michelle Sternthal, who is Director of Government Affairs at Community Catalyst, as you heard previously. So let's just dive right in. The question we had teed up was, what does the landscape for medical debt solutions look like under the current administration? But in all seriousness, there's a lot happening right now. I can't keep up hour to hour, but if you all have a view, maybe this is a good time to tell us where you think things are and where they might be headed. Why don't we start with you, Michelle?
Thank you. Is the microphone on? Okay. Things are really dark right now. There is a proposal that is serious in the House that estimates are at least almost 14 million people would be losing coverage for no good reason, for cruelty. And that, let's be very clear, that will explode medical debt and people are going to die. CAP has an estimate, I don't know how they did it. They did some estimates on the number of people who will die as a result of this. They are trying to, through a death by 1,000 cuts, roll back Medicaid. They're also stripping away affordability on the ACA, so on the exchange. They are penalizing and trying to dissuade states from using their own revenue, their own sources to cover immigrants who are undocumented. And they are trying to put provisions that would ban any dollars towards gender-affirming care, as an example. So I'm a big picture visionary person, and in this moment, there is like an all hands on deck defense. So all of you, especially if you don't live in DC and are enfranchised, I encourage you to call your member of Congress and senator and just, outreach. Go ahead.
Yeah, so I think Michelle hit the major points. Maybe I'll hit on a few more of the stats and the specifics here. So the overall, the Energy and Commerce Committee yesterday for over 24 hours marked up their portion of the budget, and that includes a $715 billion proposed cut to Medicaid, which is about an 8% cut over 10 years. So every year there would be 8% less Medicaid funding, and that's sort of a conservative estimate. The things in there are included are nationwide work requirements, like more strict and more frequent eligibility checks, other things that make enrollment more difficult. There's also increase of cost sharing for enrollees. So this is people making, I think Vikas, you mentioned this earlier, $15,000 to $16,000 a year having to pay $35 out of pocket for services. Medicaid enrollees, yes, that are like expansion population folks, and also just some other provisions that are going to increase the burden on state budgets. So this is really harming everyone, and that's just on the E&C side. On the Ways and Means side, which I think has gotten less attention, there are also some really damaging things that Michelle, as she mentioned, are going to impact marketplace enrollment for kind of that like middle income Americans. It's going to make enrollment a lot harder. It basically shortens the open enrollment period, takes away provisions that help lower income people enroll in marketplace coverage when they need it. And that just those things alone that are basically just rolling back some Biden era regs will lead to about 2 million people losing their coverage. And that doesn't include all the indications that we've gotten from the Republican side that they do not plan to extend premium tax credits, which will make marketplace coverage unaffordable for millions of families. So all the things taken together will be about 14 million people expected to lose coverage. And we did an analysis at Third Way. Obviously, there's a huge association between coverage and protection from medical debt. We were using the 880 billion number, so a little bit higher of Medicaid cuts. So this number might change a little bit, but we estimated that 2.8 million more families will have household medical debt, which would be a 10% jump and $26 billion overall increased medical debt. So sorry to throw a lot of statistics at you, very depressing, a lot different tenor than the last panel. But I think it's just important that we have that context before we jump into talking about, where do we go from here? So thanks.
Great, thank you. I'm just going to break from the script a little and just say, I'm not a Democrat. I'm not a Republican. I like Elizabeth's approach, which is let's just go with the facts and see how and where they lead us. In particular around Medicaid, I think there's a lot of factual information that needs to get shared. And I think, as I said in my opening remarks, this is not a session to talk about strategy or political tactics or anything like that. But I think it's self-evident that, there is a huge voter base that is going to be affected by this on both sides of the aisle. I just make that point. So I'm interested in talking about maybe one way to organize this is to talk about where were we at the end of the Biden administration, in particular the CFPB ruling, and then where could we be if we had a really proactive, solid approach to this question, whether it's, the Democratic Party or Josh Hawley's new Republican Party or whatever the hell it is, what could we be doing at the federal level, given everything you heard about what's going on at the states? And I'll just close that thought with pointing out that there was an entrepreneur who realized that going state by state was too damn expensive. So he bought himself a ticket to federal preemption. And that's Elon Musk.
Just on the Hawley, last week I met with Hawley's staffer to talk about consolidation, healthcare issues. So just to say that while we are doing defense, we are also ceding the ground for what we're calling the new common sense. It's not Democrat, it's not Republican. It's just people want healthcare. It's too damn expensive, and there's corporate greed. There's polling to show, no matter what side of the aisle you're on, there's outrage. And so right now, I know this isn't an answer to your question, but I'm going to say it. From a strategy level, there is a way in figuring out what is the right way to talk on both sides of the aisle to people about the outrage that they and their constituents feel. So I just wanted to name that, and we can talk more about that later. I would just say up until now, we are in an exciting moment, and we can both talk to different pieces. The CFPB finalized a rule that, while not perfect, really went a huge way in banning medical debt from credit reporting or having it be considered in terms of credit worthiness. We were also, there was huge political momentum had the elections gone a different way. I was in conversation, I'm sure you were also, with Harris folks about medical debt being one of the singular issues that they were going to focus on from a wealth and racial wealth distribution component. And we were also working behind the scenes to get the IRS to step up its compliance, which was sorely lacking on very mealy financial assistance enforcement policies. And so there were things being teed up The CFPB also issued an advisory that sort of gets to the private right of action component, where they basically were saying, debt collection that is wrong is illegal. Whoever is doing that, they will be held responsible. Hey, folks, you should know that. And using that, again, as another point to say that this is something that you can push back against. There's more, but I'll shut up and let you continue for some of that.
Thanks, Michelle. Michelle was working with our team on everything that we were working on from the Biden admin side. So you've covered a lot of it. I think just a couple other things is when you have an administration that is excited about an issue and engaged, even if there is not movement on the legislative side or even through formal regulation, there is a lot of power and just the bureaucracy that is the federal government, like really leaning into an issue. So as Michelle touched on, CFPB was working on things, engagement from IRS and other agencies. CMS definitely has a role to play here. We even had some engagement from like VA and DOD healthcare providers. So when there is an admin that's super interested in medical debt, there are improvements to be made on the margins through guidance documents and agency enforcement and just time and money being invested from the agency perspective that can really move the needle in ways that don't necessarily permeate, the national headlines. So I will say that is one thing, and that work maybe will continue in this next administration, but I don't see indications that it will. But you never know. And sometimes those things can continue to happen in a way that we aren't reading about every day in the New York Times. So we'll say that. And then secondly, outside of the like medical debt specific context, just to share a little bit about where we were from healthcare as a whole, during the Biden administration, really proud that we reached historic rates of uninsured rates. So it is the lowest it has ever been in the history of our country. That's because the enrollment in the marketplace doubled during the Biden administration from about 12 million to 24 million. A lot of that is due to premium tax credits and just a lot of investment from CMS on outreach and getting the right people enrolled. So that was a huge success for us. Also, additional states expanded Medicaid, which also had a huge impact. And a lot of those things, I think, as we've discussed with the 14 million people likely to lose coverage if this reconciliation package goes through, like that progress will roll back as well. But I think that gives a decent picture.
And on the future, so I'm going to be a little bit spicy here and say that I tend to like really hate looking at healthcare policy when I'm as a public health person. When I look at health outcomes and I look at health coverage, I often find that healthcare policy is way too narrow. And so I want to propose some ideas that I think both in the political window, but that also we as like health advocates have missed the boat on, is looking at healthcare as an industrial policy framework, as a sector that has issues on the supply and the demand side, that it, like any other sector, has a role in terms of the government's relationship to it in terms of markets, and that it should be treated in that way, and it hasn't been. And what we have right now are a series of monopolies, mega, conglomerates, vertically and horizontally integrated, consolidated, that are using their excess market power in ways to spike costs. Like we all know that. So we should be looking at antitrust policy, FTC. We should be looking at DOJ. We should be looking at tax policy. We should be looking at labor policy. We should be looking at, and I think maybe we should instead of, and look, my organization is doing this, so I don't mean to trash on myself or them, but like essential health benefits as a component or actuarial value is one conversation. Banning, profiteering is another conversation. So I would look at what are the tax policies that from a pre-distributional perspective discourage mergers? What are the policies, what are antitrust policies that make it so that it's harder for hospitals to merge? What about having the threshold for mergers with FTC authority be lowered so that, more hospitals are accounted for? So I'd look at carried interest loophole. Anyway, those are the types of things I'd be really excited about in rethinking about our healthcare system to really get at the major drivers of the cost and access.
I think we have now I work at Third Way. We have a series called Fixing America's Broken Hospital System. So we do a lot of work looking at why hospital costs are so high and how we can bring those down. I think the competition point that you brought up, Michelle, is definitely something that we're working on and support. More competitive markets are more affordable markets. So that's something that I think we need to continue to promote. A couple other things that we've worked on that I think could help address the root cause of the incredible cost of care at hospitals. Just taking a look at nonprofit status for hospitals that are nonprofits, which is about half of hospitals, they're getting $15 billion or more in federal tax benefits, and then $15 billion or more of state and local tax benefits each year. So just making sure that we are giving those benefits and having requirements that those hospitals are providing community benefits in a way that is real and is impacting people and helping their communities through, maybe that's charity care, maybe that's other things, but just making sure those requirements to get that IRS status as a nonprofit hospital are clear and require transparency and reporting so that we can have the data on the government side to make sure that these hospitals are meeting standards. Some other things that we can talk about more, but I know it was brought up in an earlier panel. Facility fees are something that are driving up costs for so many people, and oftentimes they may even be baked into the overall cost of the service. So someone doesn't even know they're getting charged a facility fee, but there's like a million examples, but patients are charged double when they go to get an ultrasound at a hospital or a hospital-owned clinic as opposed to a freestanding independent physician office. For chemotherapy infusions for cancer patients, they can pay triple if they're at a hospital, and sometimes also a hospital-owned clinic. So not just the physical hospital building, but these facility fees are being tacked on. Yes, that's what I was gonna bring up as well. There's also stories of people getting charged a facility fee for a telehealth appointment, so they're getting their service in their home, which. Yep.
Yeah, so these are, I think, all interesting examples, and I suspect we in the audience could crowdsource a federal program that would really take a huge leap forward in this problem. Michelle, I was really interested in what you said because last fall, I think it was at a conference here, Jerry Anderson of Hopkins, was talking about how he saw a kind of cyclical phase of thinking about healthcare reform, and we may be in an upcycle of that. And I think it was there I made a similar point, which is that, the thing that no one dare speak its name, industrial policy, has increasingly become the official policy of the Democratic and Republican parties. If you look at a lot of what Trump's doing now, regardless of whether you think it's effective, but the thrust of it is a form of industrial policy. Same is true for the Inflation Reduction Act. So we're seeing a sea change, in my view, at least compared to 10, 20 years ago, of where and how people are willing to rethink some of these things. And I think healthcare, is ripe for that kind of rethink on both sides of the aisle and all across the country. And, I had a $150 facility fee for a telehealth visit for 15 minutes in Boston. But let's be clear, it's not going to be coverage. Like, even if the Medicaid cuts happen, which it looks like they will, most of the country is covered. In Boston, in Massachusetts, we have something like 98.5% insurance coverage. I think Hawaii is higher, and that's about it. And yet, independent of KFF, we've done a survey in which 40%, interestingly, almost the same number of people are very concerned and avoiding health care because of the threat of debt. So we're going to have to tackle costs. We're going to have to tackle insurance design. We're going to have to tackle all of those things. So I want to hear, I think we got plenty of time. I think in this audience, we probably have a lot of people who have thoughts and ideas. What could we do at the federal level that doesn't have to go state by state by state? Could we have a standardized, like a FAFSA for college? Could we have a standardized financial assistance application form that's national? I mean, there's a range of things we could do.
I think we start off with, there are low-hanging fruits to start off with. Like, let's look at the most egregious actors. Let's look at the most egregious excesses and let's regulate that. And then I think whoever talked about insulin, was it you? I don't remember who it was, Elizabeth, but talking about insulin, like, why don't we, again, industrial policy, why don't we have sort of the, generic public provisioning of basic life-saving medicines? Like, it's not going to like kill the industry. They're not making profit. Like, what are some things that we could do actually that is actually under, the Defense Production Act? We could probably do it anyway right now if we had a different president. What are some of the low-hanging fruits? Like,
and this president's taking a leaf out of Bernie Sanders on some of the drug pricing things. So lots of things could happen. Let's hear from the audience. Who's got questions? Who's got comments? What a shy bunch.
Chuck Bell from Consumer Reports. So one of the reasons we have high medical costs in the U.S. is high unit prices. Our unit prices for many things like MRIs or COVID tests are much higher than the costs in other countries. So that is an issue that I would think would appeal to people who design the economy and thinking about how could we get greater efficiencies, economies of scale, perhaps by insourcing or onshoring some of these production things. One example might be pharmaceuticals. On the one hand, we're putting tariffs on imported drugs, which would probably be a big hit to consumers. But there have been recent efforts for nonprofit companies to manufacture generic medicines that are often in short supply. So that would be something that I would think would fit into this the line of thinking that you're articulating here.
also including the workforce side as we talk about industrial policy, and whoever talked about one of the challenges, I think you said it, one of the challenges of like a Medicare for all would be the pressure it would place on providers. Like, what are the workforce development components of it? Like, why do doctors have medical debt? I mean, or debt from medical school? Like, that feels really stupid to me in terms of like, as we're thinking about what we want to be incentivizing, you know.
Cancel student loan debt, but that's a whole other
Right.
beast, and free tuition at public universities, but that's a whole other beast. But connected. I wanted to go back to something you said, Vikas, which is that in Boston area, like 90-something% of people are covered, yet 40% still avoid healthcare because they're worried about debts. Is there any breakdown to show how much of that are the people who are covered via Medicare, Medicaid, or the VA system? Because I'm wondering how much those individuals worry about incurring debt compared to people who are privately insured. And I'm asking that because I'm married to a veteran who constantly goes to his appointments with no fear at all, and I'm always jealous. So that's my question.
Yeah, I don't have those breakdowns. It's something we
I
can
have
look at.
them.
But 40%.
It's on one of my note cards. This is the national, not the Massachusetts number, but 30% of adults with employer-based coverage and 33% of adults with Medicare or marketplace coverage. And again, that's people who currently have coverage. Does that mean the debt was incurred when they were uninsured? Maybe. So it's not a perfect picture, but definitely people who are uninsured have more medical debt. But like we were saying, coverage does not necessarily protect you. Adequate coverage protects you. So we talk about it from the third way perspective of the cure for the short-term cure for medical debt is adequate coverage. The long-term is obviously bringing down the costs on the hospital side. Sorry, if you had other things to add about Massachusetts, I just had the stats right here, so I wanted to share.
Is there a difference in the amount of debt between those two groups? Because is it like a fraction? For instance, the folks who are publicly covered, is their debt like a fraction essentially of the kind of debt that the privately insured folks have? Like, do you do any breakdown in terms of how much debt each group has?
I would just say there's a conflation factor of, by definition, if you're going to be eligible for Medicare, you're going to be older, which, so you'd have to also just like, it's a harder thing given its universal program to be comparing. I'm not adding a complicated.
Yeah. Well, this sort of harkens to something I was saying earlier, which is a lot of times when we talk about these and talk about the numbers, we talk about rates. And really in epidemiology, there's a difference between the rate and the burden. And we really should be talking about the burden. And when you look at the burden, that's what I found so astonishing when I was looking through the numbers. Whether or not the numbers are slightly off in one direction or another, what's really clear is that the burden, in my view, happy to be corrected, the burden is substantial on working people in this country, insured working people.
The VA, by the way, I said my parents are like my focus group, so my dad worked is a doctor at the VA. He was also in Boston at Joslin Diabetes Center, nonprofit, and then at BU Medical Center. He's like, the VA was the best experience ever, like from all the reasons. And so I'm like on the VA bandwagon for like a model of public.
Hi, I'm Aija with People's Action. We've got a Care Over Cost campaign focused on insurance, and when you're talking about insurance, that made me perk up a little extra. Because a lot of what we're seeing is claim denials. Like in addition to the issue of deductibles and copays, claim denials themselves and prior authorization denials are a huge driver of medical debt. We've got a new report coming out about that Mike has done some research on. In New York State. So would love to talk with folks about that. But I'm curious, how y'all see the way that insurers are not necessarily living up to their end of the bargain being part of all of this equation.
Well, and by the way, Mike, you should share some of your findings, even if it's not yet published. We can get you the mic. My own view is that the insurance well, I have a real bias here. My own view is that the insurance companies have dropped the ball on any kind of their social responsibility relative to the cost issue. They have become content, and I learned this the hard way. I'm not talking just ideologically. In practice, in talking to them and working with them, I learned the hard way that they actually have zero interest in cost control. They have interest in cost control for the year of the contract.
Yeah, of course.
So they can control it. But after that, it doesn't matter. It's an elevator and they're happy to ride it up. And so in many ways, I think the question of cost, in the sort of Godzilla versus Mothra between big hospital systems and big insurance companies, that issue is left hanging and the consumer is left holding the bag. Mike, I want you to share that data because I think it's a mixed bag. What it shows in part is that a lot of the denials are from the obvious fragmentation of the system as a whole. Mike, you want to give us a quick précis?
Sure. Thank you so much. So we are preparing to release this report about data in New York. Covers primarily post-service coverage denials. And as no surprise, the denial rates are very high and the appeal rates are very low. But perhaps surprising is the amount of money tied up in appeal overturns in New York. Not maybe surprising to people who are very familiar with this space, but maybe to the general public. So in this report, we found that roughly $3 billion were overturned via internal appeal processes in 1 year in New York. And the appeals that are not sought for wrongful denials often lead to medical debt in commercial contexts, at least. So I think the relation here is to what extent do wrongful denials and lack of enforcement contribute to this major medical debt problem that we see? And maybe on the federal pathways question, I'm very curious as to your thoughts about whether, for example, like the HHS-OIG approach to overturn inappropriate denials and overturns, and maybe also DOJ investigation into False Claims Act types of approaches are going to continue, or whether that landscape has shifted enough to make it unlikely. I'd have to look at the report. I don't know off the top of my head. Yeah, the appeal rates are between like 0.5% and 2%.
You see,
Yeah, to me, the most striking thing is the appeals rates.
Yeah.
These are tiny appeals rates, but if you appeal, the overturning of the original decision is huge, which tells you, a lot of
these are wrongful.
A lot of these denials are wrongful. Yeah.
I think we're thinking about this. I think there's whoever mentioned, was it ERISA, as like the stepchild that never really gets focused on. That is an area we're really concerned with. I think that there is looking at claims denials or prior auth in that area. It's harder because like there's a big focus right now on Medicare Advantage as a tool, but we think that's a critical area. And we should talk because I think this is something that we're looking at the least. There is some transparency requirements that could be upheld, that if we again had a HHS that was resourced, we would push them on in terms of reporting of non-qualified health plans, but like broader. And on the other, like to your point about no interest in healthcare, just like a quick anecdote. I'm a cancer survivor. I'm supposed to get right after my cancer treatment, I was supposed to get PET scans every 3 months because there was still some residual, whatever they call it, radioactivity or whatever. And the United Health Insurance, which People's Action has a campaign against, Michelle, said that it was not part of the standard of practice. So my oncologist called and said, no, this is important. And they said, no, I'm sorry, we don't do it. And they said, no, really, this is quite important. We need to do it. They're like, you're being overly, whatever the term is, like overly cautious. But instead, what we will authorize is a separate MRI and PET scan. MRI and CT scan. So instead of getting the PET scan, they authorized 2 separate, more costly tests that I had to have, that I ended up having, that was substandard and cost more. And so to me, this epitomizes the sort of the stupidity of a system that, yes, all of the things there.
So, yeah, I know we have lots of them, and I want to get to them. I can't see who has the mic, unfortunately. Okay, great. The one thing I wanted to say about your data, Mike, that struck me as related to what Michelle just said is that the number of claims that were officially denied for medical necessity, I was actually surprised at how small that was. Most of the reasons for the denials were all about the fragmentation of the system. This is a duplicate claim. Your coverage date was not right. This happened, that happened. It was all about administrative trivia and not really about clinical care, as you outlined. So I think this whole area just illustrates, how messed up it is. Sorry.
Yeah, so I think to that point, and I raised it this morning, but simplifying billing is really key, and that's really key for the insurers, the providers, and of course the patient at the end, to actually understand and find the errors and find the and be able to scrape data in a way that everyone can understand it and know about it. And then yes, for sure, we have AI bots talking that have denied a claim, talking to the doctors, AI bots that are saying, no, what this is why it's medically necessary. So this is a situation we're in, and it's not going to get better. But one thing I would like to flag, and I'd love to hear from anybody who's hearing this, but what I'm starting to hear about now are these one-off weird charges that patients who are insured are getting charged directly to them. These bills are not being sent to insurance companies, they're just being sent to individuals. And you may have experienced this yourself, but I hear it particularly with OBGYNs charging kind of like a maintenance fee or, stay an active patient fee, even though the provider is in network. They're being charged, patients are being charged, and I think it's, I'm sure they've done the market research. I've heard $350 a year in California and $150 in the DC area. And, if you have ever had a child or an OBGYN problem, you love your OBGYN. You do not want to go through the process of finding someone else. And I don't know that everyone gets kicked off their list if they don't pay. Why not charge people $350 a year? If only 10% pay it, great. I think our insurance contract should be prohibiting these additional charges for any in-network provider. And people need to know that they're illegal. I mean, they aren't right now, but this should be in a contract by our insurers. If you're going to be in network, the only thing you can charge a patient is, based on our negotiated rate. So,
Well, I'm not a lawyer, thank God, but that was, and I suspect remains, illegal if it is assumed to be just part of a fee in the kind of relationship between the practice and the patient without an additional contract. The model you're describing 10 or 15 years ago became a model of concierge care in which you provided a fee. The East Coast version was, it's $20,000 a year. The West Coast version was it's, $50 a month. But either way, this was a form of a wraparound service with a separate contract, which then allowed the physicians and the practices to say, hey, we'll actually return your calls. That's not actually part of our contract with the insurance company, but for a fee, we'll give you a great deal. So it sounds to me it's something like that, but maybe it's morphed into something that is so, completely beyond the pale. So that's a concierge.
We haven't done any specific work on this, so I can't speak to this specifically, but I will just say, especially for OBGYN services, especially in more rural parts of the country, there is such a shortage of providers. I think it's about 1,000 counties in the country that have no obstetric unit, so they have no ability to help a woman give birth. So I think especially just sympathizing with this, you feel as though you have to pay it because you don't want to lose your provider. And I mean, if you live in DC, maybe you can go see another provider, but if you live in the middle of nowhere, you have to pay it if you want to be able to drive 2 hours to birth your baby as opposed to 4. So I think that is just speaks to our need for more providers, especially in care deserts, especially for maternity care. Again, not really what we're talking about today, but just wanted to call it out because it's such a big problem.
Well, it is what we're talking about today because one of the drivers of that is hospital consolidation, the acquisition of private equity, and profit-driven medicine, which is saying that maternity wards are not profitable, so they close, and then you end up with things. It's not a coincidence on where it's happening. Yeah, and exactly, it's related to that. So it's all one circle of misery.
Well, speaking of one circle, I mean, this is where you need a whole system approach because the issue of community benefits, precisely those services that are not, quote, profitable are services that are meant to be part and parcel of a community benefit package, and it's erratic how that's enforced or not enforced or reported or not reported. Question back there.
Hi. I have a question. It's kind of related to the last discussion we had here. So I will make a reference to something that Fred said in the beginning. We have done a lot of studies on the determinants of medical debt, and consolidation is important, price of care is important, health insurance coverage important, but the most important thing is the health status of the population. And I think there is always a lack of discussion of how can we promote better health behaviors, how can we do better in terms of preventive care. And I think addressing those would be core, especially when you think about other countries too. So I was just wondering in terms of federal policy, state policy, I haven't heard anything about that.
I feel very strongly about this. So I'll just say two things. This is what I got my PhD in. So health disparities, even if there's 100% coverage, there would be glaring disparities because the drivers of health and poor health is not having health insurance. That exacerbates it. These are economic, and this is about social and physical environment. So I would say to you, it's not about health behaviors. People don't say, oh, I really want to be lazy and sick. It's what are the material and economic conditions that enable certain people to go to my favorite bougie bar 3, which I love to go to, versus I'm working 3 jobs I can't afford. I'm living in a place that is higher, propensity of having asthma, and there's no grocery in the location. So I would say the major factors are, let's look at eradicating poverty. Income. There's Richard Wilkinson is one of the researchers who's talked about how income disparities are associated with health outcomes. You can look at stuff like my advisor David Williams will talk about this, neighborhood segregation. So it's very easy. So I would 100% agree, and let's do that. And I would say let's move away from cooking without salt, which is important, or whatever. But there's all these other factors that at a population level are going to move the needle.
Oh yeah, The Spirit Level, great book. Let me just add a little to that, because Brenna, I think in a system I'm going to sound like a broken record, in a system in which the patient is expected to fork over some money when they're sick, I think it's impossible to disaggregate the confounding that you're talking about. Confounding of, social determinants in a population with low income, health, behaviors that are not necessarily healthy, conditions in which they're not really healthy, all of those factors, to disaggregate them, no matter how good the study is, I think it's impossible. You're going to have a ton of correlation, and there's just no way to sort of say, well, that the medical debt part of that, could be alleviated if they were healthier. If grandma had a beard, she'd be grandpa. So.
I think that epidemiologically, though, you do know that there's racial disparities in health outcomes in morbidity and mortality. And if we have correlations between morbidity and mortality and medical debt, right, people who are sicker tend to accrue more medical debt, which is what we talked about, then if you have people become less sick, definitionally, I think you would get less. So the first thing is, people who are, if there are certain communities, low income, people who've been discriminated against, people who have multiple morbidities, and they're the ones who are eventually going to the ER because of lack of coverage and then exploding their debts and all that. These are patterned, socially patterned. Cancer is, lots of things are patterned. So address the patterning and then you'll address the debt.
I also think this is not exactly related to your point, but something I feel about the medical debt discussion. I think because it's medical debt, it's financial, people think that this is something that only impacts low-income communities, and that's not true. Data from the SIP data actually shows that the rate of medical debt among middle-class households is actually a little bit higher than in low-income households. It's 23.5% or 17 million middle-class Americans, and compared to 22% low-income Americans. So I think we have to talk about health outcomes. I think we have to talk about a lot of things that are driving medical debt. But one thing that I think kind of gets lost in this discussion is that this is not something that just impacts the poorest of folks. It impacts people across incomes, even people with really high incomes. It impacts 1 in 8 of those folks because the cost of care is so high. So.
Hi there. I'm Jessica. I'm a student at Rutgers School of Public Health. My question is about, someone mentioned like OB-GYN departments closing because they're less profitable. I'm also a medical student, so I've been in some conversations with older physicians who would say things like, you know, hospitals used to understand that some departments were less profitable than others. And that was just a norm, and everybody understood that was the cost of running a hospital. And that in recent years, there's been more and more and more pressure for each department to create its own profit or increase revenue in any way that they can. And so I'm kind of curious, like, we haven't yet talked about private equity in healthcare or venture capital in healthcare, like, and what are the forces that have changed these norms in hospitals where different kinds of behavior has become acceptable over time? So my question is about that.
Yeah, private equity is a huge component of this, of generally of like the profit driven. You're seeing it penetrate now OB/GYN and women's health, but it's also in almost every other sector, ERs, if you look at where the fragmentation of care is another issue. So I would say I'm not going to speak to exactly why there are closures in different rural areas, because there's like a number of different factors in rural areas that make it complicated to fully say it's that, like losing population, maybe worse health, other things. But yes, the sort of the private equity and what are the policy drivers of how do you address that is an issue that we, along with our partners at the Private Equity Stakeholder Project, Americans for Financial Reform, and others are keenly aware of and working on, particularly because I see it, there's no net positive. Like, I don't know any private equity intervention in healthcare. Say it again? Ooh, if there is a counterexample, I'd love to hear it. So I think, like, I mean, my vision is like, I think we need to ban private equity in healthcare altogether.
And I know we've talked about it, but outside of just private equity, I think the larger consolidation issue is huge here. We have anti-competitive hospital markets, and when two big hospitals in a community merge, they may decide it's more economical to only have one obstetrics unit. And I think the fact there's a million factors that are sort of incentivizing more consolidation that I think we need to address through really smart policy decisions to make sure we are not losing access to care.
Well, I don't disagree with that. I want to add something, which is when you look at the trends, whether it's CEO compensation, administrative layers in hospitals, board composition, it didn't all begin with private equity or VCs. This has been going on now really since the 80s. It's part and parcel of a kind of sea change, both in the culture of the country, but also particularly in healthcare. And I raise that because when I look at this pattern in this picture, the reason private equity is there is something to be gotten. And that is because we've structured and organized, particularly the hospital sector, as if these are concerns like the local car dealership. And if you can make money, you make money. And if you make money, you get more money. Yourself, even if you're a nonprofit, you get a higher salary, you get this, you get that. And so fundamentally, and I think this is, I don't know how we get there politically, but fundamentally, this is about everybody, and I mean everybody in the country, thinks of healthcare in their heart of hearts as a social good and a public utility. When they're on the line, that's what it is. Left, right, Democrat,
So
Republican, whatever. That's what they think and feel. But then when you look at what we've structured it as if it's this other thing. And that category error, I think, is the biggest driver. We expect hospitals to be in the black. And sure, they should be. They shouldn't be hemorrhaging money. But there's no reason in the world why they have to be in the black to the tune of hundreds of millions or billions of dollars. And that's all about the fact that if there's a surplus, it's private and somebody can do something with it. That structure of the healthcare, of the hospital marketplace is fundamental. And until that changes, we're going to have this problem.
So two things. One is Community Catalyst just did some polling on that. I was really interested in, to what extent do Republicans, in addition to Democrats, think of healthcare as that's something that should be a public good? what should be the role of the government in intervening. And the results are really striking and exciting, and we're going to be sharing it. And I think it's part of the narrative component, which is really important to shift this. I would say at a policy level, let's start with under the TCJA, there's a requirement for an excise tax for CEOs who make above $1 million. That if a nonprofit entity has that, they're supposed to pay, I think it's about 20 to 30%, including hospitals. The form to report that is private. Why don't we have that being public? Let's see which hospitals are charging their CEOs. If they're charging them that much that they have to have an excise tax, maybe there should be some change in, let's do that. How much are they spending on advertisement? Should we have a requirement that on every advertisement there should be a line that says, by the way, there's financial assistance policies for each that we are legally obligated to provide? So I do think that there are small things getting us there that we could be doing, and happy to talk afterwards about them, because as you can see, I like to talk.
Our time is up. So this is a great segue. We have a break, but this is a great segue to the next session, which will be general systemic topics and issues on this issue of medical debt. So come right back.